the main clinical dilemma that you really are faced with is when you have a patient that has a biochemical failure, um, you need to determine whether curative intent salvage treatment would be appropriate. And the main issue is that you know that some cancer is present due to the biochemical failure, but you don't actually know where that cancer is at. So whether it's still locally present in the prostate or has metastasized, you can't actually say, which then can make physicians more hesitant to aggressively treat this cancer. Yeah, you want to do what's right for the patient as a physician, and you want to offer them a potential cure if at all possible. And that was what inspired the idea for the project. Essentially, it tells us that advanced imaging can be, essentially increasing confidence of physicians. So our data showed that patients are more likely to be aggressively treated, and as you know, it was twice likelihood. And this can be beneficial instead of futile, which I think is a question a lot of people were asking. Like, is this testing worth it? Is it worth it to order it? Are we answering new questions? And I think the answer is yes. I think that the benefits outweigh the risks and financial costs of the imaging. When you're able to, effectively note at a very low PSA level where the cancer is located, you're able to be far more aggressive. Seeking out the most sensitive modality that you have at your disposal is very, fruitful. It allows you to confidently state, I'm going to be aggressive about salvage therapy at that time. The main limitation really is genomics, like prostate cancer genomics. A good example would be breast cancer. We can get early stage patients to have genomic profiling performed, which helps determine the recurrence score and determines whether chemotherapy should be given. And it's possible that eventually, someday, we could have an analogous prostate cancer test that sort of determines if a PSMA PET negative prostate cancer patient would benefit from salvage radiation, but no such testing exists right now. The future is looking pretty cool. The main things that I think are interesting to note, right now we mainly use this testing for staging and restaging, and it's possible that later we could use it for a guided biopsy or even characterizing the cancer before biopsy. Both of these indications aren't currently utilized. We could also use it for theranostics and for when you do the radioligand therapy. Currently, or essentially we could guide how many cycles of therapy are needed by getting an immediate response on what the cancer response has been. And then in general, regarding oncologists, I think that utilization is going to increase over time, and we're going to increase the oncologist's confidence in their treatment pathway. And I think that will lead to more and more aggressive therapies over time and hopefully better outcomes for prostate cancer. Specifically in terms of being more aggressive before metastasis has occurred.